Bismillah ar-Rahman ar-Rahim. Today we have VIVA Session number 17, neuro cases. I am Dr. Muhammad Talat. Dr. Dalia Ibrahim will join us in our session. Welcome to ERA, Easy Radiology Approach. If you want to interact with us, you will find the link of our WhatsApp group in the first comment of this video. I will scroll for you, okay, to save your time. This patient came to the ER complaining of acute disturbance of conscious level, acute disturbance in conscious level. Okay.
This is CT axial.
Okay. Okay.
Showing there is a hypodense area seen at the right periventricular area, and
Okay.
there is no effacement of the lateral ventricle and no
Okay.
shifting of the midline.
Okay.
And
where is this hypodense area? Where is it located, please?
This located in the right hemisphere, cerebral hemisphere,
Okay.
in the periventricular area and frontal lobe of the cerebral hemisphere.
Okay.
There is no effacement of the lateral ventricle and no shifting of the midline.
Okay.
يعني
okay, you did very well. If I want to compare this area
with the presence of the middle cerebral artery sign.
Yeah, very nice. Okay.
That's the middle cerebral,
so
the
what's
right
your final
cerebral
diagnosis?
artery.
Okay, so what's your final diagnosis, please?
Infarction of the right hemisphere, cerebral hemisphere.
Okay. Acute infarction along the territory of the right middle cerebral artery. Okay. Let's describe for you. Any case coming for you in the ER, you should first start to scroll the CT brain as you did. And please, I want to hear from you. I want to see the stroke volume. Stroke window, please. Stroke window, that means that I'm doing like this. Look for this one.
Yes.
It's grainy, but it's diagnostic. Look for the abnormality here. It's very easy to see this abnormality located at the right basic ganglia, right lentiform nucleus. Look for this lentiform nucleus. This is a normal, and this is abnormal. So we have hypodense area located at the lentiform sinus. The lentiform sinus appears ill-defined, so it's called lentiform sign. And also, if we compare the insula, look for the insula here. This insula is hypodense. Yeah, yes. It's not like the contralateral sign. So we have insular ribbon sign. Also, we have MCA sign. So we have features of early or acute ischemic insult along the territory of the right middle cerebral artery. We don't have any significant mass effect or hypodense area in the peripheral cortex, but we have other three signs of acute ischemic insult. I would like to add something very important. In any case of acute infarction, we should make like a score to measure the volume of the cerebral infarction. We have something called aspects. Okay, aspects. This one, how can we measure the volume of the cerebral infarction? Simply, we give 10 points for the infarction along the middle cerebral artery. If we need to give these 10 points, we will give the caudate nucleus 1 point, the internal capsule another point, the basal ganglia another point, and the insula another point. Yes. And then we will give M1, M2, M3. Okay. In this pattern of affection, we have the lentiform and the insula. Okay. Yes. So we have 10 points. What are these 10 points? The caudate nucleus, 1 point, internal capsule, another point, lentiform nucleus, another point, insula, another point, and also M1, M2, M3. So those are 7 points. When we go more in the higher slice, we should go this one also 1 point, another point, another point. So we have 10 points. In these 10 points, we have only 2 points affected. So we have 8 regions are preserved out of 10. So our score here is 8/10. So we are counting the normal brain tissue. Okay.
Yeah.
If we have aspects 6 or lower, so this one is bad prognosis. If we have higher than 6, 7 to 10, we have a good prognosis. Also, if we want to add one of the factors that determines the prognosis of the middle cerebral artery infarction, we should measure the length of the dense sign. Dense sign reflects the intraluminal thrombus. If the dense sign or if the intraluminal thrombus more than 8 millimeter, so this one is considered as a bad prognosis. Also, if we have something like brain herniation, any signs of brain herniation, we don't have any signs of brain herniation. So this is considered also one of the bad prognosis. So our bad prognosis if the aspects 6 or below, if the intraluminal thrombus more than 8 millimeter in length, if we have any signs of brain herniation. Okay. Thank you so much, candidate number 11. Just I want to show you this case. This is another case. And this case coming for the ER with almost the same complaint. And as you see, we make a stroke window. This is the classic features of acute stroke along the right middle cerebral artery involving the whole segments. So this one is score 0 because it is affecting the whole territory of the right middle cerebral artery. Also, we have something like midline shift or super added midline shift. How can we determine the midline shift? We are drawing something this line along the midline, and from this midline, you can measure from the foramen of Monroe till the midline, almost 8 millimeter. So this the way that can you measure the midline shift. Okay, so we have in this case midline shift and subfalcine herniation, and this one is considered one of the bad signs for bad prognosis. Okay, we can go to the next candidate. Can we go to the candidate number 1? Is candidate number 1 present or not? Candidate number 1, are you present?
Yes, sir.
Okay. Candidate number 1, this patient came to you in the ER complaining of right side hemiparesis, acute hemiparesis. Okay. I will scroll for you. Give me the idea. This patient is 68 years old.
Okay, this is 68-year-old patient. These are the deep-embedded axial slices of the MRI brain, in which I can appreciate multiple T2 hyper-intense foci in the bilateral periventricular deep white matter, which is extending up to the level of zona radiata and centrum semiovale, suggest ischemic changes likely pulmonary infarcts, and there is an signs of atrophy in this patient.
Okay.
Some of these lesions are centrally low in appearance, represent chronic infarcts. Another flare area is appreciated in the region of the temporal lobe.
Okay.
I want to
Can
say
you
that
please check the diffusion, please? Okay.
yes. These are multiple areas on the left side, which are seen in the watershed areas at the junction of ACA and MCA territory.
Very nice. Perfect. Yes.
Yes, so I am concerned about the embolic infarcts in these patients. So, each echo and carotid Doppler study is suggested to evaluate the source of thrombus in this
So
patient.
we have acute infarction. What type of acute infarction? You told me that this one is watershed infarct. Acute watershed infarct. What type?
Yes.
Which type of watershed infarct?
Sir, these are acute type at the junction of ACA and MCA.
Okay, we have 2 types of watershed infarcts. Do you know these types?
No, sir.
we have either internal type or external type of watershed infarcts. Okay, this is considered as internal type of watershed infarcts. By the end of this session, I will show you the external type of the watershed infarcts. Okay, how
Okay.
can we determine the watershed infarcts? How can we diagnose watershed infarcts? Do you know the criteria?
Sir, mainly when these are at the junctions of the two territories.
Okay, we have we should have more than or equal three lesions, and we should count at least out of from these three should exceed 3 millimeter. Okay, in dimension.
Okay.
So, and also should be in this linear fashion, as you can see here. Okay, this is in linear fashion. So we have multiple nodular white matter lesions are present in the corona radiata and centrum semioval. Here in the centrum semioval, here in the corona radiata. So we have multiple nodal lesions in a linear fashion. So this one is keeping with acute watershed infarcts internal type. Okay. Most likely watershed infarcts are present or are developed secondary to hypoperfusion, not embolic disease. Okay, embolic disease and hypoperfusion can cause external type watershed infarcts, but most likely the internal type is caused by hypoperfusion. Okay, can you keep with me? Can you see with me this case, please?
Yes.
This case complaining of acute hemiparesis. If you want to scroll, if you want me to scroll, okay, I will scroll for you to save your time.
Okay, sir.
The patient complaining of acute hemiparesis.
Okay, these are T2 weighted sagittal images of the MRI cervical spine of an adult patient, in which I can appreciate straightening of the cervical spine along with degenerative changes and multi-level disco-osteophytic disc bulges at the level of C3, 4, 4, 5, and 5, 6 levels.
Okay.
At the level of C4, 5, it is causing marked compression over the cervical spinal cord with internal hyper-intense signals which are concerned for the compressive
Very nice.
changes.
Okay.
I want to see the axial star and axial images. Okay, that on the star, these are hyper-intense too, which confirm the compressive myelopathic changes.
Okay. Can you see any other abnormality?
Sir, in the visualized section, there is no tonsillar herniation. And
Very nice.
there is ossification of the posterior longitudinal ligament is also seen at the level of C5, 6, and C4 level.
Okay, but can you ignore this point, please? Can you focus again for any other abnormality?
In the marrow altered signal seen, likely these are age-related modic changes.
Okay. Can you please apply your checklist? As you said, if in any case of cervical spine, when I start to report any case of cervical spine, really I should start by this scout, okay, to check any masses, any abnormality. I consider the scout as a screening tool, okay? In any case of spine, MRI spine, lumbar, dorsal, I will start by the scout, then I will go to the stage 32. Before checking the vertebrae, disc spaces, and disc lesions, and spinal cord, and the spinous processes, in my routine practice, I would check other parts at the edge of the film. Can you please start to check any other abnormality?
Sir,
you
there
checked
is
the foramen magnum, very nice.
yes.
We don't have anything in the, no, we don't have any descent of the cerebral tonsils. We don't have any abnormality in the brainstem. Clivus is normal. Atlantoaxial joint is
I
perfect.
can appreciate an hyper-intense, well-defined hyper-intense lesion adjacent to the upper thoracic
Very
spine.
nice. Perfect. Perfect. Candidate number 2. Perfect. We have a lesion located at the prevertebral space. Is that correct?
Yes, yes.
Okay. It's opposite which is 2, 3, 4, 5, 6, 7, D1, D2. Opposite D2 vertebrae. Is that correct? Okay. Really, when I started to report this case, I mentioned that we have a prevertebral lesion and need further, and this lesion needs further assessment. And really, we did we did MRI for this case, focusing on this mass lesion, as you can see here. This is the axial T2. I will zoom in. Can you see this one? Can you please help me in the description of this mass lesion?
Sir, it is located behind the esophagus.
Very nice. Okay.
It is causing compression over it.
Okay.
And it is well separable from the aortic arch and descending thoracic aorta.
Perfect. Okay. I will show you the whole sequences. Okay. This is
The
axial
lesion
T1.
is well defined, bright on the T2 star and ISO on the T1 if the post contrast is available.
I will give you the post contrast. This is the post contrast.
Yes, and the post contrast shows marked post contrast enhancement.
Yeah, intense contrast enhancement. So
Yes.
is it solid or cystic?
It seems solid.
Solid, yeah. Okay, agree.
Yes.
Okay, so this one is present, or it is it? I think it is located in the prevertebral region. Okay, retroesophageal in location. It is mostly indenting and displacing the esophagus anteriorly. It doesn't erode or destruct the vertebral body posteriorly.
Yes, it seems benign structure.
Yeah, it's smooth in outline, capsulated. Really, we are following this case now for more than 5 years, and it is stationary. Okay, so what's your differential diagnosis?
So it can be the ectopic thyroid tissue.
Ectopic thyroid tissue, okay. But the ectopic thyroid tissue, okay, but it's very difficult to have ectopic thyroid tissue in this location because this one is considered as a posterior mediastinum. Is that correct?
Esophageal duplication cyst because it is not separable.
Okay, esophageal duplication cyst, but this one is not cystic, but you are thinking very well. Okay, what else?
It is not the location of the lymph node, but
it can be lymph node, but it is not signal wise of the lymph node.
Yes.
And the lymph node will not be present for 5 or 6 years. What are the most common cause for posterior mediastinal mass?
It can be the neurofibroma Shivanoma.
Yes, can be neurogenic. Yes, correct. Can be neurogenic. Can be either nerve sheath tumor, neurofibroma, schwannoma, or something like this. Can be arising from the sympathetic chain. Can be arising from the parasympathetic chain, paraganglioma, or something like this. So we have neurogenic tumor, most common. If we are thinking that what are the posterior mediastinal masses, or what is the differential diagnosis for posterior mediastinal masses? It's very easy. Don't memorize yourself. Please think for the anatomical structures, and you can pick up the differential diagnosis. You can say esophagus, esophageal tumor, esophageal duplication cyst. It's not cyst. Maybe aneurysm coming from the aortic arch. It's not aneurysm. Maybe in the nerves passing here. So neurogenic tumor can be lymph node. Can be lymph node. Can be coming from the vertebrae, like meningioma or something like paravertebral hematoma, paravertebral abscess. We don't have anything or infectious process at that point. If it is coming from the bone, can be chordoma, can be chondrosarcoma. The bone is very well. So this one, it's away from the bone, away from the esophagus, away from the vascular structures. So this most probably neurogenic tumor. Okay. And this is benign features of the neurogenic tumor. It's not malignant features, but we should follow up this case to check malignant transformation or malignant changes, malignant features of the neurogenic tumor. Okay.
Okay, sir.
Okay. Thank you so much. Can we move to the next candidate? Candidate number 3. Are you present? Candidate number 3.
Yes, I present.
Yeah. How are you, candidate number 3? Are you ready?
I'm fine. Yes, I'm ready.
Okay, go ahead. This case came for me in the ER also, complaining of acute vertigo.
Acute vertigo.
Yeah.
So this is the CT scan brain non-contrast images.
Yes. Okay.
There is a hyperdense area is noted in the left parieto-occipital lobe in parasagittal
Yes.
location.
Very nice. Before doing this one, please request from me that we need to do stroke window to make it more easy to pick up the abnormality. I think it is now more easy to see this abnormality. Okay, go ahead.
So this area in the left parieto-occipital lobe, which is causing the effacement of adjacent sulci in the parasagittal location, likely represent acute ischemic infarct in the
Very
territory
nice.
of left PCA.
Yeah,
In
very
addition to
nice.
this, there is some focal area of gliosis also noted in the right occipital lobe.
Okay.
Right occipital lobe.
I think maybe this one evolution changes. I am not sure this one in Malaysia for any old ischemic infarct or not. But really, as you said, the most striking abnormality is the acute cerebral infarction along the territory of the left posterior cerebral artery. This one, we can describe this one as a wedge-shaped hypodense area located at the temporo-occipital region, paramedian in location, slightly abutting the trigone and temporal horn of the left lateral ventricle. Can you see any more abnormality here in this slice?
In addition to this, this is also extending superiorly in the left thalamic region. There is suspicion of
very nice, very nice. Perfect. This one is the left thalamus. We have small hypodense area in the left thalamus. Okay, is this one is matching with the territory of the posterior cerebral artery?
This is also territory of the left PCA. So this is also involving the left thalamic region.
Why? Do you have any explanation?
This because left thalamic region is supplied by the PCA territory.
Yeah, it is supplied by the salamo-perforating arteries, okay, which supply the left thalamus here in this case, okay. So this one is considered apart from the PCA territory, okay.
Yeah.
And also, can we move to the next case? Please keep with me, okay.
Yes.
Okay. This case, can I show you the CT scan of this case? Yeah, this case came to the ER, and the patient complaining of headache.
Okay.
I will scroll for you, and you can. If you want me to stop scrolling at any slides, tell me. If you want to scroll by yourself, send for me a request for remote control as you like.
Okay, this is the age of the patient.
The age of the patient, 69 years old, female patient, complaining of headache.
So this is non-contrast CT scan.
Okay.
Brain images in which there is obviously there is no frank change is seen. There is no acute infarct is noted.
Yeah, very nice. Okay.
No evidence of any intracranial bleed is seen.
Okay.
But I want to see the Silvini fissure again. The left MC artery appears to be dense.
Let us review the MCA. MCA, I think this density is almost the same for the contralateral side.
This bilateral,
Yeah,
so
okay.
The other thing is that the cavernous sinuses appears slightly hyperdense bilaterally.
And
that is symmetrical hyperdense cavernous sinuses.
There is
no mass effect is noted. I want to see the post-contrast images to see any thrombus formation in the governance sinuses.
Can you see this one? Okay,
The
maybe
ventricle chain appears to be dead.
can you see here? Can you concentrate on these slices?
Yeah,
Can
on
you
this
see
scan,
any abnormalities? Okay.
yeah, in this scan, this is post-contrast.
No.
This
It's
is
still
this.
non-contrast scan. Yes.
You see, there is a hyperdensity as seen in the governance sinuses, especially on the right side. This is extending inferiorly, causing some mass effect on the brainstem. The effacement of the preponton cistern is noted.
Okay.
The ventricular chain also appears to be dilated. So this like may be infective in origin. I will want to see the post-contrast MR scan.
Okay.
And to see the clinical condition of the patient. If the patient is paraxic, this may be some infective etiology. The patient age is 69 years. We cannot exclude
we don't have any signs of inflammatory process in this case. Can you describe or can you please give me more details about the location of this lesion?
There's a hyperdense mass lesion is seen in the governance sinuses bilaterally, more marked on the right side, with the obscuration of the right IC. This is extending inferiorly into the causing extrinsic impression on the brainstem with effacement of the prepontine cistern.
Yes, it's effacing the prepontine cistern. It is located as a prepontine cistern, and it's extra-axial in location.
Yeah, I will also want to see the bone windows.
I will give you the MRI study for this case. Let's concentrate more in this area.
So on this MR scan, there is a mass on the T2 weighted images. There is a mass lesion is seen in the.
Very nice. We have a mass in the prepontine cistern.
Prepontine cistern in the area of governance sinuses, right governance sinuses extending inferiorly. This is the extra-axial mass lesion. This is causing compression on the brainstem. It appears due to
it's abutting or slightly bending the
low
brainstem.
signal on
Okay,
T1.
very nice.
This appears low signal on T1.
This one is T2, so it displays iso-10 signal in the T2. No problem. I will give you the T1. Okay, this is the T1.
T1 is slightly hyperintense as compared to the T2. So these find
more or less iso-intense.
More or less extra-axial region. I want to see the post-contrast. This may represent
I will give you the
meningioma.
post-contrast. Okay, this is the post-contrast.
On meningioma, this is an intensely enhancing lesion.
Yeah.
And with a dural tail appearance.
Yeah, very nice. Dural tail. And
so
this one is dural based. This one, an extra-axial dural based mass lesion resting upon the clivus. Look for the sagittal. Yeah, look for the sagittal.
On sagittal, this is again extra-axial location and with dural tail appearance. This likely represent meningioma.
Yeah, very nice. Okay, this one is considered, really, it's typical case of Clival meningioma. As you described, we have extra-axial mass resting or with dural based against the clivus. And this mass lesion displays iso-intense signal in T1, slightly low signal in T2 with intense homogeneous contrast enhancement. So again, in the CT scan, we have an extra-axial mass, maybe meningioma, are reported like this one for further MRI assessment. The differential diagnosis, as you know, may be aneurysm coming from the internal carotid artery, any abnormality coming from the sinus, but really in this case, it is a typical case of Clival meningioma, and also you should comment on its relation to the basilar artery. It is slightly touching the basilar artery. This one is very important for any surgical interference. Okay, thank you so much. Candidate number, are you candidate number 3 or 4?
3.
3, okay. We need candidate number 4.
Assalamu alaikum, Dr.
Wa alaikum assalam wa rahmatullah. Candidate number 4, before starting with you, I would like just this case to review this case rapidly. This case is of acute cerebral infarction of the left middle cerebral artery. You can see also the dense MCA sign. You can see the infarction involving the caudate, involving the internal capsule, anterior limb of the internal capsule, lentiform nucleus. Also, it's involving some of the peripheral brain tissue, cortical and subcortical, and in this area, and also involving the insula. So this one, I think if we can give a score for this one, let us count this one, codate 1, 2, 3, 4. Then these 3 segments are spared. Then 5, 6. So 6 segments are affected and 4 segments are spared. So this score is 4/10 aspects. Okay, so you should add your score. You should add your score. And this one is MRI brain for the same case. I want to show it to the other candidates. This is the classic features of acute infarction. If you want to see, this is the diffusion. Okay, high signal in the diffusion and low signal in the ADC map along the territory of the mid-cerebral artery. Just I would like also to add something. If you have any case of acute cerebral infarction, if you are sure of acute cerebral infarction, as in this case, we have different signs that delineate or that diagnose this case as acute cerebral infarction. So you are sure. So please, before starting to report this case, please call the interventional radiologist, activate the stroke team. If you are insuspicious, that you are not sure, is this one is dense MCA sign or not, we don't have any other signs of acute cerebral infarction, please, if the patient is prepared to do CT angiography, do CT angiography on the spot, okay, to diagnose, is this middle cerebral artery is occluded or not, if this dense MCA sign, is it properly present or not. So all of these features, this is the guidelines, okay. If the patient is complaining from neurological deficits and you couldn't pick up any abnormality in the CT, MRI can help you to detect any acute ischemic attack. Okay, so this is the guidelines in any case of acute stroke. Let's go to this next case. Yeah, this case.
I am presented with
this case really I will give you the age. This patient is 18 years old and she complains of headache, recurrent attacks of headache. Okay.
Okay. I am presented with the MRI brain axial view T2 image, in which I can see there is right cerebral hemisphere atrophic changes.
Okay.
هما bilateral mainly في right side.
Yeah, bilateral what? What type
bilateral
of abnormality?
atrophic changes.
Okay, I will give you, this is the axial T2 and this is the flare. Okay.
And flare, it's hyper intense atrophic changes with hyper intense REM.
Okay.
نفس الشيء mainly في right side.
Okay. So we have focal widening of the cortical cell sign. Is that correct? Okay.
كأنها glycotic changes.
Yeah, very nice. We have an evidence of gangliosis on bilateral frontal regions. Okay, more on the right side. Okay, very nice. Okay. So this one can reflect that we have an old insult.
أيوة كأنها.
Is that correct?
laminar necrosis.
Okay. Do you have any other abnormalities?
فيه multiple signal flow void في ال basal cistern.
Okay. Perfect. You are amazing. Okay. Tell me more. What do you have here?
مش عارفة.
You told me a very nice sign.
You have brain في جهة atrophied right side.
You have, please concentrate again.
في multiple signal flow void.
Multiple signal void structures.
أيوة. More than normal.
Yeah. It's a network of vessels. Okay. Do you have any idea?
هذه picture of Moya Moya disease.
Yeah, you are perfect. You are perfect. Okay, this one, I will show you the MR angiography for this case because we requested to do MR angiography. And as you can see here, we have focal narrowing, focal attenuation of the terminal end of the internal carotid artery, more on the left side. And we have multiple collaterals in the basal cisterns and in the basal ganglia. This represents multiple dilatation or multiple collaterals along the lenticulostriate arteries. And this one gives you the sign of puff of smoke. Is that correct? Puff of smoke. So this one can be Moya Moya disease or Moya Moya syndrome. Do you know the difference? How can we differentiate, or what is the difference between these two terms?
I think if the patient is symptomatic, is syndrome, is disease. If the
How
patient
can
is
we
symptomatic,
differentiate? Or what is the difference between Moya disease and the Moya Moya syndrome?
I think it's if the patient is symptomatic
disease?
or no.
Are you sure?
No, I don't. No, I'm not sure.
Moya Moya disease is an idiopathic. Okay, I will tell you. Okay, I will help you. Moya Moya disease is an idiopathic disease. Okay, not atherosclerotic, not infection, not inflammatory, not nothing. Okay. Moya Moya syndrome is secondary to either other diseases like sickle cell anemia, myelofibrosis. Something can be secondary to infection, can be secondary to inflammatory process, vasculitis, or connective tissue disorders. This is called the Moya Moya syndrome. Okay. You can raise the two possibilities in your report: Moya Moya disease, Moya Moya syndrome, because the clinician should search for any association or any underlying cause for this Moya Moya pattern. Okay. Just I would like to add something very important for this case. When I was a resident, I think I was a resident on 2002 or 2003, something like this. I was in the I was in the interventional radiology unit, and we diagnosed the case with, I think the case was presented with subarachnoid hemorrhage, and then we discovered that the case is Moya Moya disease. So Moya Moya disease or Moya Moya syndrome in the childhood, in the early age group or age of 4 years, 5 years, the case will present by ischemic changes. Okay, so in this case, this one is considered as old ischemic insult during childhood, and in the adult age group, 30 or 40 years, the patient can present by hemorrhage, not by ischemic insult, because of these multiple collaterals. These multiple collaterals can develop microaneurysms, something like AVM. It's not AVM, but something like AVM can present in the later age group, can present by different types of brain hemorrhage. Okay, so take care of this different presentation in any case of Moya Moya. Okay, can you keep with me? Let's go to see this case. Just a minute. This case, what do you think? This is a case. This case, we didn't present this case in the last session. This is a new case. Let us finish by this case. Okay. This case really came to me presenting with acute right side hemiparesis. Okay.
I am presented with CT scan brain, non-enhanced axial section, in which I can see there is hypodensity involving right posterior frontal, left frontal lobe.
This one is left and right.
أيوة هذا.
Okay. So we have hypodense area along the left high, left high parietal region. Okay.
وهي كأنها مش واصلة للكورتكس، يعني mainly
في الديب وايت very nice. Okay, the cortex almost preserved. Okay.
أيوة mainly في الديب
وايت. So this subcortical hypodense area is present or It is located in the subcortical region. Okay. Okay. So do you have any suggestions?
هي مش هتكون acute ischemic infarction لأنه لو كانت acute ischemic infarction يعني should involve الوايت matter.
Yeah, very nice. This one is yeah. Okay.
Arterial infarction.
Okay. So this one is considered like vasogenic brain edema. I need to hear this term. This is not cytotoxic. It is not cytotoxic brain edema. Okay. It's vasogenic brain edema. Yes.
I want
because
to see
it's finger-like projection and preserving the cortex itself. Okay.
So I want to see if there's a post-contrast image to see if there's underlying mass lesion.
Okay. Okay. Very nice. Okay. By the way, there is something inside.
Yes, it's there's something.
There is like nodular lesion inside. Okay. So what's your differential diagnosis in this case? Before going to the post-contrast study.
Maybe it's metastasis.
Okay, maybe. You're right. What else?
I will see the contrast to see.
Okay. Okay.
To,
I will
to narrow the differential.
I will give you the MRI. Not yeah. Okay.
I am presented with the MRI brain axial T2 scan, in which I can see there is a mass lesion with hypointense foci in the center.
Okay.
Surrounded by moderate vasogenic edema, disproportional vasogenic edema.
Okay.
في الفلير كانت دوت ساين حتى هي السنتر بتاعها هايبو انتنس.
Okay. Very nice. Okay. So we have a well circumscribed. If I want to describe this lesion, I will say either I will start by the lesion or I will start by the region. Okay. I can say the left high parietal region is a seat of subcortical, well circumscribed, rounded, space occupying lesion. Okay. Then I will describe the lesion. The lesion displays high signal in T2 and high signal in FLAIR with central area or central dot of dark signal. Okay. I will give you the post-contrast study. This is a post-contrast study. Okay.
In post-contrast study, there is ring enhanced.
Yeah, ring enhancement. Complete ring enhancement. It's not incomplete. Yeah, complete smooth ring enhancement. Okay. Okay. What's your differential?
I will see diffusion.
Okay. Can you give me a differential diagnosis for ring enhancing lesions?
Ring enhanced lesion, maybe it's abscess with central diffusion restriction. Maybe it's metastasis.
Yeah.
Glioblastoma multiforme.
Okay. Glioma. Okay.
I will differentiate between the metastasis and the glioblastoma by MRI spectroscopy.
Okay.
Maybe بس يعني اللي هم لمسوا هيك بس هدوما incomplete ring enhanced.
Yeah. MS
maybe
or
tuberculoma or
maybe
neurocysticercosis.
Okay. Very nice. Okay. I will give you the diffusion and I will give you the ADC map. Okay. May help you. Okay.
ADC. في diffusion restriction في البريفرال.
في peripheral. Yeah, you are right. Okay.
Not abscess.
Okay.
Not glioblastoma.
I want to add something. If we want to differentiate between abscess and metastatic lesion, you should know. Yeah, as you said, the center of the lesion or the lesion, the whole lesion. If it is totally restricted, this one will be abscess or metastasis.
Abscess, central diffusion.
Abscess, yeah, central, yeah. If the center also is restricted, so this one is abscess. If the center is not restricted, we should think of metastatic lesion. Yeah, but also I would like to add something. This lesion shows smooth, rounded outline. Okay. Really, when I started to report this case, the case or this patient is an adult patient, and he had a history of diabetes type 1 with low immunity. So we really I'm not sure is this one is abscess or metastatic lesion, but I would like to add something also very important. If you compare the diffusion and the ADC almost the lesion
very low.
shows complete,
Very low.
almost complete low signal in the ADC. Which sequence you will be confident on, the diffusion or the ADC? To tell you the type of restriction, is it totally restricted or not? Which one is more sensitive for the diffusion restriction, the
Diffusion.
ADC or the diffusion? The ADC.
Diffusion.
The ADC. The ADC is more sensitive for the diffusion restriction. Sometimes the diffusion, as you see here, the dot, the center dot is not restricted, but the diffusion almost complete restriction. So abscess is more I think it's
يكون more dark في ADC.
Yeah, it's more priority than metastatic lesion in this case, but really I should write both diagnostic possibilities. Really, this case underwent operation and proved to be brain abscess. Okay. Then, alhamdulillah, later on the patient did very well and partially recover his neurological deficit. Okay. And we are following this case later on now for more than 6 years or 7 years with area of encephalomalacia, but this case proved to be small brain abscess. Okay. I think I finished our cases today, but just I would like this case, as I told you, that I will show you the watershed infarcts. As you can see here, this is an old internal type of watershed infarcts, and at the same time we have wedge-shaped area, cortical and subcortical areas between the territories of the middle cerebral artery and the posterior cerebral artery, and also between the anterior cerebral artery and the middle cerebral artery. This one is considered external type of watershed infarcts. Okay, so we have here, as you see, this is the external type of watershed infarcts, and this one is the internal type of watershed infarcts. The internal type can make a sign called string of pearls. String of pearls means like سلسلة فيها لؤلؤ كده، يعني سلسلة فيها لآلئ. This is can be similar to internal type of watershed infarcts. We have I would like to review with you the early signs of acute cerebral infarction: MCA sign, insular ribbon sign, basic ganglia sign, loss of gray-white matter interface, and hypodense area. Sometimes you can see mass effect of this hypodense area, like effacement of the cortical sulci. You can see all of these signs, and you can see 1 or 2 signs of these 4 important signs for cerebral infarction. Okay. Also, we reviewed the aspects. It's important to mention this one in your report. The caudate 1 point, internal capsule 1 point, lentiform insula, then M1, M2, M3. M2 is lateral to the insula, M1 is anterior to the insula, M3 is posterior to the insula, and in the higher slice, this one is called M4. M4 is above or superior to the M1, M5 is superior to M2, M6 is superior to M3. Okay, so we have here 4 points and then 3 points, so we have together 7 points here and 3 points here, so we have almost 7 points. Then we start to calculate our aspects. Aspects means Alberta stroke program, early CT stroke. We will mention, for example, if the caudate lobe is affected, putamen affected, internal capsule affected, insular cortex is affected, then the other segments are not affected, as you can see here. So we have the non-affected segments are 6, and the affected segments are 4. So we have the final score is 6/10. Okay, you can mention this one in your report. We mentioned also the signs of bad prognosis in any case of acute cerebral hemorrhage, in any case of acute cerebral stroke or acute cerebral infarction. If the aspects below 6, intraluminous thrombus or dense sign the length of the sign is more than 8 millimeter, any type of brain herniation. So these are the signs of bad prognosis. We also mentioned the posterior mediastinal masses, esophageal. So once we have a posterior mediastinal mass, it's easy to memorize yourself. You will ask yourself first, what are the normal structures that present in the posterior mediastinum? First, the nerves, neurogenic tumors. This is the most common. Nerve sheath tumor, schwannoma, neurofibroma, malignant peripheral nerve sheath tumor, sympathetic chain tumors, either neuroblastoma, ganglion neuroblastoma, ganglion neuroma. Neuroblastoma is the most aggressive. Ganglion neuroma is the least aggressive. This one is intermediate in aggressive features. Parasympathetic ganglion tumor, for example, paraganglioma. So we have nerve sheath tumor, sympathetic chain, parasympathetic chain. For the vertebral and the disc in between, we have either congenital diseases like thoracic meningocele, neuroenteric cyst. You can suggest neuroenteric cyst if you have a cyst adjacent to the vertebrae, and the vertebrae that's present beside the cyst shows vertebral anomaly. Trauma, if we have a trauma case, paraspinal hematoma, infection, or spondylodiscitis can be associated with paraspinal abscess. Neoplasm, if we have destructive lytic lesion inside or involving the vertebral column, chordoma, chondrosarcoma, even sarcoma, metastatic lesions. All of these are examples for posterior mediastinal masses. Then you can shift to the esophagus, esophageal neoplasm, if we have exophytic neoplasm arising from the esophagus, esophageal duplication cyst from the esophagus, lymph nodes, if we have lymphoma, vascular structures, aortic aneurysm, lymphangioma, hernia, if we have a lower posterior mediastinal mass, hiatus hernia or buccal hernia, extramedullary hematopoiesis if we have abnormal marrow signal in the vertebrae, bronchogenic cyst. We have another differential diagnosis for cerebral ring enhancing lesions, metastasis, abscess, or septic emboli, glioma, infection again, abscess infection, but I repeated the infection again because this one is bacterial infection. This one infection either TB, toxoplasma, tinea solium, like neurocysticercosis, infarct, contusion, demyelinating disease, radiation necrosis. I have misnomer here that may help you. Magic doctor. M for metastasis, A for abscess, G for glioma, I for infection. Infection we have 3T, TB, toxoplasma, and tinea solium. C for contusion, D for demyelinating, R for radiation necrosis. Okay, so we have magic doctor. This is our misnomer that can help you to memorize or to recall the cerebral ring enhancing lesions. Okay, this is the first part of our session today. Let's shift to Dr. Dalia Ibrahim to complete with you this session. Thank you.
اوكي بص يا دكتور، احنا عندنا this is a 2-year-old male وهي complains of mid-dorsal cystic swelling not covered by skin since birth. بصوا انا معيش الشكل بتاعه كلينيكال، بس عشان اقرب لكم الشكل هو الشكل ده قوي. يعني هو جاي بيشتكي بحاجه زي كده، ان هو سيست في الباك وما فيهاش كفرنج بالسكن. طيب نرجع بقى للحالة بتاعتنا كده ونشوف. يلا candidate number 1.
Should I start?
Yes, you can start.
Okay, these are the axial slices of the MRI dorsal spine,
Yes.
T2 weighted images, in which I can appreciate normal curvature of the thoracic spine, vertebral body heights and disc spaces are normal, spinal cord retrieves normal signals. I can appreciate well-defined soft tissue, well-defined cystic lesion seen within the subcutaneous tissue at the upper thoracic spine, which is well-defined margins, and its overlying skin is not intact, and there is
Yes.
and there is a fibrotic band is which is starting
Yes.
from
You
its
are amazing. What's your name?
Amna.
Amna, you are amazing, Amna, because you have described like the anatomy of the disease. Okay, continue.
Okay, there is a fibrotic strand or band which is passing through the interspinous ligament of one of the dorsal lumbar vertebra, and it is communicating with the posterior thecal sac. And there
Yes.
is a subtle herniation of the CSF and the sac through this track into the interspinous space. I would like
I
to.
just want to add something. If you focus in on the T1 with the images, you can imagine that the fibrous stalk can extend inside the spinal canal and is attached to the spinal cord at this point. I don't
Yes,
know if you can see this clearly or not. Can
yes,
you
yes,
see this?
yes, yes.
So, as Dr. Amna said, we have a subcutaneous cystic swelling أو cystic lesion وذا ثانية واحدة معلش أنا عندي في مشكلة جامدة في الصوت. With no skin covering overlying وfibrotic stalk extending from the cystic lesion extending through the interspinous region to the spinal canal, then deep to the spinal cord, attached to the spinal cord, causing tethering of the spinal cord at the site of the union with the spinal cord. Okay, do you want to see the other sequences?
Yes, I want to see the axial images.
Okay, you can move as you want.
Okay, and the axial images at the same level, I can appreciate the posterior elements seems intact. However, it is passing through the level of intervertebral disc space. I think this fibrous tract is communicating with the posterior cervical canal.
Yes.
But posterior elements does not deficient at this level.
I can tell you something.
Yes, yes.
Can you see this part?
Here I can see that yes, they are deficient.
Yes, there is a subtle sign of spinal dysraphism here in this part where the stalk is pathing. There is incomplete fusion of the posterior neural element. I know it's hard to see this in MRI, but if we perform a CT scan for this patient, I think it will be much more clear. If you can see here, we have subtle widening in the interspinous region at the site of entry of this fibrous stalk. Okay,
Yes.
so we have subtle signs of spinal dysraphism. Okay,
Yes.
this is the final sequence I wanted to show you that this patient had contrast enhanced MRI and there is no enhancement in any of the lesions we have described. So just to illustrate what Dr. Amna had mentioned, we have three major pathologies in this case. We have a subcutaneous cystic lesion with no skin covering. We have a fibrous stalk extending from the cystic lesion, passing through the interspinous region and deep inside the spinal canal, reaching the spinal cord, attaching to the dorsal aspect of the spinal cord, causing tethering of the spinal cord at the site of attachment. Okay, what I really loved in Dr. Amna's description is that she described this as a fibrous stalk. She didn't say that this is a sinus tract. Okay, but she rather described what she is seeing exactly like the pathology. This is like a fibrous tract. And we have finally subtle signs of spinal dysraphism in this case, like widening of the interspinous region at the site of entry and the incomplete fusion of the posterior neural element at the level of T4 in this case. What is the most likely diagnosis in this case, Dr. Amna?
This is a case of spinal dysraphism with meningocele.
لا no, okay. This is a subtype of spinal dysraphism. We agree with this, okay? But why this is not a meningocele? I tell you, like in this picture, you can see the cyst is confined without no definite communication with the meningocele. In cases of meningocele, you can see the meningocele exiting from this part, okay? Myelomeningocele for Mela, who mentioned. No, I'm talking about the whole entity, like myelocele or myelomeningocele. You can see the cyst exiting from the spinal cord and extending to the interspinous region or the subcutaneous plane. But in this case, no, you can see the cyst is confined. It's like it's a separate lesion, or like Dr. Rami Edward described it in the conference. It's like entrapped myelomeningocele. Okay, not communicating, but we do have a fibrous stalk communicating with the spinal cord. Okay, so this is a subtype of spinal dysraphism, but not with myelomeningocele. Some radiologists call this dermal sinus tract, and we will discuss later if this is a diagnosis or no. Thanks, Dr. Amna. I will proceed with the next case. Do I have a candidate?
Yeah, case candidate number 2. Are you present? Candidate number 3. Candidate number 3. Candidate number 4.
Okay, I proceed.
Okay, you can proceed, Dr. Dalia. Candidate number
Okay.
5.
If you want, anyone want to share, okay, I will be happy.
Dr. Dalia, tell them that your cases are easy, please.
They are easy cases. يعني كدبة حرام في رمضان، هم مش easy. أنا لسه عارفاهم أساسا.
Okay,
Yes,
we
candidate
are
3 here.
starting.
Candidate 3 here. Can I talk?
Candidate number 3. Okay, go ahead. Go
Yes.
ahead.
Okay.
Okay, go.
I will tell you the history before you get started. This is a 12 years old female. She is complaining of headache and the neck pain. She had a history of previous meningitis. Okay. So
Okay,
I will show you the MRI of the cervical spine as first, and then the MRI of the brain.
Okay, this is cervical spine T2 weighted sagittal images. Here I can see the setting of cervical spine where there is some disc bulges are seen at the C5, 6, C5, 6, C6, 7 level with a mild compression of the adjacent thecal sag. The cord appears normal. There is no evidence of transfer herniation as seen on the T2 weighted images. I could not see any abnormality in this T2 sagittal images.
Okay, can't you see any abnormality?
No, I could not see. There is setting of cervical spine. There is small linear changes. There is small disc bulges. There is no other.
Okay, go.
I will tell you the history before you get started. This is a 12 years old female. She is complaining of headache and the neck pain. She had a history of previous meningitis. Okay. So
Okay,
I will show you the MRI of the cervical spine as first, and then the MRI of the brain.
Okay, this is cervical spine T2 weighted sagittal images. Here I can see the setting of cervical spine where there is some disc bulges are seen at the C5, 6, C5, 6, C6, 7 level with a mild compression of the adjacent thecal sag. The cord appears normal. There is no evidence of transfer herniation as seen on the T2 weighted images. I could not see any abnormality in this T2 sagittal images.
Okay, can't you see any abnormality?
No, I could not see. There is setting of cervical spine. There is small linear changes. There is small disc bulges. There is no other abnormality I can see in this surgical T2 weighted. This is 12-year age. 12-year age.
What?
This is 12-year age. 12-year.
12 years old.
He is
Yeah,
12.
there is the setting of cervical spine is noted on the T2 sagittal images. I could not see any abnormality in the cord.
Okay, if I get you this sagittal stare, can you identify any abnormality? Before you say, I don't have any abnormality, move your eyes all through the case. You have focused on the vertebrae, on the discs, on the spinal canal, on the spinal cord, but you forget to look at this region, the posterior aspect.
The posterior aspect, there appears to be some the spinous process are not seen. This could be represent some surgery, post-surgical changes.
No, she didn't have any surgery.
And on there is about 5-6 level. There is small disc bulge, but on this stage it should be not be present.
Yes,
and
no,
there is some linear
focus on this.
deficiency.
Focus on this abnormality.
There is some fibrotic band is seen.
Not fibrous, actually, it's like a sinus tract. Okay,
yes.
Not like the other case. The other case it was like a fibrous stalk, like Dr. Amna said. But here I can see a sinus tract extending from a skin opening, and then there is a sinus tract filled with fluid, has a thick hypointense wall, and then extends deeply through the interspinous region to reach the spinal canal. اوكي ده
Yes.
يعني الحالة دي انا دايما بحب اقولها الاول. عايزة اشوف الشكل ده. بصوا المنظر ده هي البنت دي السكين اوبننج اللي كانت عندها. تمام ماشي. يعني هي جايه اوريدي بالشكوى بتاعتها سكين اوبننج، وارجوكم عايزين نركز مع الموضوع ده كويس قوي، عشان الفرق بين الامراض اللي احنا هنقولها دلوقتي دي مهم جدا الكلينيكال، ومهم جدا هل في سكين اوبننج ولا لا. اوكي طيب نيجي بعد كده. ادي عندي المنظر اهو من السكين اوبننج اللي عند البنوته دي. في عندي ساينس تراكت اكستندنج من السكين اوبننج ديت، ودي في السبكوتينيوس والانتر سباينس والواصل لغايه السباينال كورد. هل شادد على السباينال كورد؟ لا مش صحيح. اوكي هو اباتنج السباينال كورد. اوكي في الساجيتال تي 1 فات سات بعد الصبغه لقينا التراك كله واخد صبغه. اللي بيكتب بريئنا الفيستولا هو نفس الشكل بتاع البريئنا الفيستولا، نفس الشكل والمنظر بالظبط. ما في اسكان اوبننج وساينس تراكت واصل بدل الريكتم ولقينا الكنال واصل لغايه السباينال كانال، فهو نفس الشكل بتاع البريئنا الفيستولا، ونفس الصبغه اللي هي ان تعرفك ان الساينس تراكت ده يعني ان اكتيف انفلاميشن دلوقتي. اوكي وده يفسر لنا الشكوى بتاعت البنوته ان هي كان عندها ريكورنت اتاكس اوف meningitis. اوكي زي ما هنقول later on. في الاكزيال تي 2 we do have spinal dysraphism عند بصوا دي الفتحه بتاعتنا في skin opening.
Can you please describe the lesion again in English words, please?
Okay. So again, this girl has a history of skin opening, and extending from the skin opening we have a sinus tract which extends in the deep subcutaneous planes and deeply in the interspinous region, reaching to the spinal canal, abutting the spinal cord but not causing any tethering of the spinal cord. Okay, this tract is epithelialized. What does that mean? That I do have epithelial lining with retained secretions and subsequent infection, super added infection. Okay, this girl had the history of previous meningitis. Okay, and this is the MRI of the brain. Dr. Mujahid, do you have any comment on this MRI of the brain of the same girl?
There is the dilatation of a ventricular chain is noted. There is fourth ventricle, third lateral ventricles are markedly dilated.
Yes, there is marked dilatation. This is an acute or a chronic dilatation?
This appears to be acute dilatation. There's a marked dilatation of the third and lateral ventricles. I want to see the fourth ventricle.
I will show you the fourth ventricle. The answer of the first question is this is a chronic dilatation. Why? Because we don't have any CSF permeation. Okay, this is a chronic form of hydrocephalus. Why this? He wanted to see the fourth ventricle, which is dilated or not dilated.
It is not appears to be. So this appears to be non-communicating hydrocephalus.
What? I didn't hear you.
This appears to be non-communicating hydrocephalus. Fourth ventricle appears normal.
Yeah. Yes, amazing. And also you have the cause of obstruction. Where is this?
This could be aqueductal stenosis.
No, you can see here whips. There are small whips here obstructing the distal part of the aqueduct of Sylvius. That's why the fourth ventricle is collapsed, and we have marked dilatation of the ventricular system. Okay, so how can we describe what happened to this girl? That she had a previous recurrent history of meningitis with like some sort of fibrosis and adhesions, and those adhesions had less, as we can see here, those are fibrotic bands or webs obstructed the distal part of the aqueduct of Sylvius, leading to this marked A supratentorial ventricular system dilatation. Okay, so we have seen the abnormality here, which was the start of the story. Okay, we have a skin opening, we have a sinus tract which is epithelialized, leading to retained secretions and superadded infection, which had spread to the spinal canal, leading to meningitis, which had spread to the brain, leading to the marked hydrocephalus. Okay, in this case. So, and we have subtle signs of spinal dysraphism here at the level of T2. Can you see this? There is incomplete fusion. So this is another case of a spinal dysraphism. But what is the exact diagnosis for this case? This is the exact, or I consider this case a textbook case for the dermal sinus tract. Okay, this is a dermal sinus tract like the textbook mentioned. Okay, you do have a skin opening clinically, you do have a sinus tract extending to the level of spinal cord, you have the typical clinical presentation, which is meningitis, and the complication of meningitis in this case, we don't have any tethering of the cord. This is a typical and the classic and the textbook case of dermal sinus tract. Okay, let's see this is a 3 months old female. Okay, she came complaining of skin appendage since birth. 1 minute.
Yeah, sure.
This is the skin tag.
Okay.
Okay, she presented with this, and her clinician sends her for MRI. Okay, this is a skin tag, but this is not a skin opening. I am focusing on the opening and any other skin abnormality, because we will describe this later. Okay.
Okay. Can I see like T2? Yeah. So I've been presented with the sagittal T2 weighted images of an MRI of a child who has presented with the skin tag, and the first abnormality while you are scrolling, I know is the evidence of spinal defect at the level of the upper cervical.
Yes.
Lower.
Here in this case, like Dr. Rabia said, we have extensive form of spinal dysraphism. We can see evident spinal dysraphism here in this case. Okay.
Yes.
Okay, you may continue.
Yes, I can see that there is a herniation of some. I believe this could be the the venous plexus, which seems to be herniating. But I would like to see it in the axial views to evaluate for the herniation of the cord at this level. However,
actually, if you can see here, I can show you the T1 with the images. You can see the cord is not herniating. And again, it's very similar to the first case. We have like a fibrotic stalk extending and attached to the dorsal aspect of the spinal cord at this level, leading to tethering of the spinal cord, again, like the first case. Okay? And focal serings in this part.
Serings.
Okay?
Exactly.
I can show you the axial T2. This is a region of the skin appendage or the skin tag. Okay.
Yeah, in the axial, I can, there is redemonstration of the spinal dysraphism. Apart from that, I can see herniation of the meninges.
Yes. Can you see a meningocele or myelomeningocele or something?
There is no definite sac formation, but definitely there is herniation of.
Yes.
But I am not able to visualize superadded sac, and the defect on the skin is overlaid, is lined by the skin and the fat.
Yes, we have here, this is the part of the skin tag, okay, which is like a fibrous tract underlying subcutaneous with very, very thin fibrous stalks, again extending through a large spinal dysraphism attached to the dorsal aspect of the dorsal spinal cord, leading to tethering and focal serings at this region. Okay, this girl had also a CT scan. Can you see this? Here we can see the skin tag with underlying fibrous tissue, or maybe a short sinus tract. Okay, and the spinal dysraphism and the spinal cord here. This is a clear spinal dysraphism, and this is the skin tag in the surface rendering images. Okay, my question now, what's your most likely diagnosis for this case? This is a definite spinal dysraphism, okay, but can we call this one dermal sinus tract? Is it similar to the first case or the second case?
Yeah. Actually, I couldn't see the first and the second cases, unfortunately. I just joined.
Okay.
So, yes, it is not a sinus because it is not draining outside.
Yes.
It is lined by
that's exactly what I want to say, okay? I have shown you a classic case of a sinus just to make you see the difference between this disease and the other disease. Okay, we will move. So, we have two distinct pathologies or two distinct diseases. They may be very similar, but they are not the same. Okay, a classic, a textbook case, the dorsal dermal sinus, like I have described. This is a skin opening with a sinus tract extending from the skin opening deep to the spinal canal. Okay, with a fluid-filled lumen, super infected, leading to meningitis. Okay, this is a classic case of dorsal dermal sinus. While the two other cases, actually, they are not, they are usually termed as dermal sinus, but actually this is not right. Okay, those are extremely rare form of spinal dysraphism. We call this limited dorsal myeloschisis. Okay, limited dorsal myeloschisis is an extremely rare form of spinal dysraphism. It is very similar to dermal sinus tract. We usually call this pseudodermal sinus. Why? Because they share three characteristics of the dorsal dermal sinus, which are a skin lesion, which is actually not a skin opening. It's a skin lesion, either a cyst in the saccular type, okay, or a skin tag like we have seen in my case, or they call it a cigarette burn mark. Okay, like in this case, this is like a cigarette burn mark. Okay, the patient will present with this mark in his back. Okay, so in this disease we don't have a skin opening, but rather another skin lesion. Okay, a skin mark, which may be a saccular, a cyst in the saccular type, or a cigarette burn mark in the non-saccular type, and extending from this cyst or from this skin mark as a fibrous stalk, like Dr. Amna described. A fibrous stalk is extending from this lesion deep to the spinal cord, okay, leading to tethering of the spinal cord at the site of attachment. Okay, ماشي. I will talk a little bit بقى in Arabic. احنا دايما بنشخص الامراض دي على ان هي ديرمال ساينس تراكت. خلاص ماشي، انا بالنسبه لي كنت منزله الثلاث حالات على ريديوبيديا على ان هم دورسال ديرمال ساينس. اوكي ماشي، وبعدين قاعده بقرا بالصدفه كده لقيت المرض دوت والسب تايب الجديد ده من السباينال ديسترافيزم اسمه ليميتد دورسال مايلوسكيسس. اوكي، هو معظم الوقت بيتشخص على ان هو ديرمال ساينس، يعني هو برضو اتس نوت راكي ميستيك يعني ان احنا نقول عليه ديرمال ساينس، بس هو الفروقات ما بينهم على مستوى الباثولوجي ان احنا دوت مش ما فيش سكين اوبننج وما فيش ساينس تراكت، ما فيش ابيثيليالايزد. يعني في الكونفرنس عجبني قوي فادي، كنت واقفه معاه بحضر المحاضره قبل البرزنتيشن قبل ما ادي الكونفرنس يعني، وبسكرول ثرو ذا كيسز فقال لي ده ديرمال ساينس، يعني بمنتهى البساطه على الحالات يعني مش فدي من ناحيه. دكتور رامي عجبني قوي قال كلمه، قال الفرق ما بين الاثنين تحت الميكروسكوب الابيثيلياليزيشن. لو انا التراك دوت فيه ابيثيليال ده هيخليني اعمل ساينس وهيخليني اعمل تشانل، تمام ماشي، ويبقى فيه سيكريشنز فيها ويبقى فيها سوبر انفكشن. لكن الحالات بتاعت الليميتد دورسال مايلوسكيسز البرزنتيشن لو العيان دوت مش هيبقى البرزنتيشن بتاعته زي ما احنا شفنا في الحالات بتاعتي، كانت ان هي جاي بالسيست او بالسكين تاج، يعني هو مش جاي بنيورولوجيكال مانيفستيشنز، خدوا بالكم ممكن ما يجيش بنيورولوجيكال مانيفستيشنز، لكن يجي بالسكين ليجنز ديت، تمام ماشي، و تكون النيورولوجيكال مانيفستيشنز علشان بس الشد على الكورد، يعني عشان التيذرنج، فعلى حسب القوه في الشده على حسب التيذرنج ده هيبقى نيورولوجيكال مانيفستيشنز، ف it may be mild it may be severe. القصد ايه ان في حالات الديرمال دورسال او الدورسال ديرمال ساينس، انت كجراح ده الارم، انت لازم تفتح وتشيل دلوقتي قبل ما عيانك يدخل في مننجايتس، ان شاء الله يكون العيان عنده يوم واحد، تمام ماشي. لكن الليميتد دورسال مايلوسكيسس احنا ممكن الموضوع لو هو نيورولوجيكال مانيفستيشن مش مستاهله والولد لسه صغير، احنا ممكن نديله هيز تشانس ان هو يكبر شويه ويستحمل عمليه زي ديت، فممكن ناجل، لان انا ما عنديش ريسك اوف انفكشن، لان عندي السكين كلوزد، I don't have any sinus tract to spread the infection to the spinal canal. الحاجه الثانيه ان التيذرنج اوف ذا سباينال كورد دي من ضمن الكرايتيريا بتاعه الليميتد دورسال مايلوسكيسس، مش الديرمال ساينس قوي. طيب في حالات الحلال مبين والحرام مبين، يعني في حالات انا هقدر اقول زي الحاله بتاعتي بتاعت الديرمال ساينس دي، انا اقدر اقول والله دي ديرمال ساينس، انا هكتبها كده. وفي حالات يعني ممكن يا داليا هي ديرمال ساينس ولا هي ليميتد دورسال، يعني مها عبد الكريم كانت بعتلي حاله هي عطلانه فيها هي وريهام وبعتتها لي، انا نفسي عطلت معاهم، يعني الحاله فعلا تحس ان فيها اوفرلاب ما بين الاثنين، ومش قادره احلف هل في ساينس ولا لا، فساعتها احنا ممكن نمشي بايه، لازم تكتب في التقرير بتاعك في الوقت ده ديرمال ساينس. يعني ليه؟ يعني لو انت لو ما كتبتش ليميت الدورسال في حاله زي دي مش هتبقى مشكله، لكن لازم نكتب ديرمال ساينس، لازم لفظ ديرمال ساينس، علشان لو انت شاكك لازم الجراح يخش يشيل، علشان ما تدخلش العيان في ريسك انفكشن وانت لسه مش متاكد من الحاجه. خلاص ماشي. انا بكتب ايه كداليا دلوقتي في الحالات اللي هي بتتبعت لي حاجه زي كده، بكتب لو هي ليميتد دورسال سباينال ديسرافيزم بين قوسين ليميتد دورسال مايلوسكيسس، يعني بكتب كده في الوصف بتاعي ان هي this is a case of spinal dysraphism بين قوسين limited dorsal myeloschisis. اوكي. وفي الوصف فوق لازم ابقى قايله له كويس قوي كل الوصف اللي انا قلته لكم، ان انا عندي سكار، او ان انا لا ده انا عندي الحاله الثانيه ديت اللي هي البنوته دي، يعني انا مش عارفه الجزء ده هل ده شورت ساينس وبعد كده مكمل كسكار، زي ما قلت في اوفرلاب بيحصل ما بين المرضين، علشان كده لو انت محتار اكتب ليميتد دورسال مايلوسكيسز سلاش ديرمال ساينس، او ممكن تكتب في الحاله ديت لو انت عايز تكتب دورسال ساينس ماشي، بس لازم توصف له ان في فايبروتيك باند واصله وعامله تيذرنج على الكورد، الوصف بتاعك مهم جدا، وتقوله الاكستنت بتاعت السب سباينال ديسرافيزم علشان تبقى انت مغطي له الاناتومي كويس قوي قبل ما يخش في الجراحه بتاعتنا. فده اللي انا عايزه اقوله النهارده. انا عارفه ان الحاله دي صعبه، انا نفسي عرفت المرض ده من تقريبا 4 5 شهور، يعني كنت منزله ال3 حالات على ان هم نفس التشخيص اللي هي ديرمال دورسال يعني. خلاص ماشي، او ديرمال ساينس يعني، تمام ماشي. فدي كده بالنسبه لنا اول حاله، الحالات بعد كده تمشي سهله جدا على فكره، دي كانت دول اصعب حالات يعني. خلاص ماشي، الحالات بعد كده ان شاء الله سهله جدا، نناقشهم مع بعض. section 2. يلا. do I have a candidate? I have
we
very
have
very
candidate we have candidate
easy
5.
case.
As
Okay.
Dr Dalia said, the tough cases passed. We are now starting
The easy
straightforward the educational cases. Okay.
Okay.
Candidate number 5, are you present?
I already did.
Okay.
Okay.
Candidate number 6. Candidate number 7. Candidate number 8.
Yes, sir.
Okay, go ahead.
Hello. Hi,
Yes.
doctor. How are you?
I'm good.
What's your name?
Sarish.
Sadish?
Yes.
Okay, Sadish. Get started. This is 50 years old male. He has a history of left upper limb weakness and numbness. Okay, I will not proceed with the history. If you want to scroll through the case.
1 second. I will ask for control.
Okay.
I've requested.
Okay, you can move through the case. And if you
Okay.
want to divide the screen.
Okay. So I've been provided with sagittal T1 and T2 weighted MR images of cervical spine of an adult patient. I
Yeah.
can see that there are degenerative changes seen in the form of disc dehydration and multi-level osteophyte formation, disc ossified formation. I can see that there is posterior disc ossified formation at the level of 2, 3, 4, 5, C6, 7, which is causing significant narrowing of the spinal canal, and there is also compression of the spinal cord with intrinsic high T2 signal within the cord, which is concerning for compressive myelopathy. This could also explain the symptoms of the patient. I do not see any additional lesion within the spinal cord or within the spinal canal.
The
Either
spinal cord, you have said that we have abnormality here?
Yes, over here.
Yes.
Yes, so this could
The axial?
Yes, so on the Excel images, I can see that there is redemonstration of the posterior left paracentral disc ossified complex, which is compressing the spinal cord anteriorly, and also the left-sided exiting nerve root. So this could represent the cause of the symptoms in the patient.
Okay. Yes, amazing.
I will inform the findings to the referring physician, and this would require a spinal surgical review for decompressive surgery.
Yes, you are amazing, Sadush. Your description is amazing. Okay, and what you have thought to the referral for the surgical consultation for decompression surgery is amazing also. Okay.
Thank you.
This we will continue with this patient.
Can you continue candidate number 8 in this case also?
Okay, if you want to share, okay.
Okay.
This is the post-operative. This 10 days after surgery, the patient presented with severe neck pain and dysphagia. Okay, and so he asked for MRI of the cervical spine.
Okay. So I've been provided with post-operative cervical spine MR images of the same patient. I can see that there are post-surgical changes with artifacts noted at the level of the intervertebral disc space of the previously operated vertebrae. There is evidence, still evidence of myelomalacic changes within the cord at this level, but there is extensive prevertebral abnormal signal intensity, which is seen extending from the level of C2 till C7, and there is intermediate signal intensity areas and low signal intensity areas on T2 red images. So this could represent post-operative collection or post-operative hematoma. I would like to look at T1-weighted images if it is hyperintense.
This is a T1?
Yes, on T1 it is intermediate signal intensity, and on T2 red images again it is slightly hyperintense. I would like to look at post
on the T2. As you can see, this is a very well-defined collection with hypointensities within.
Yes. So I would like to look at post-contrast also, if available.
No, it's not available. Okay, this is a T1, T2. What do you think of this? This is a merge sequence, okay? Multi.
So there are areas of
combined gradient
void. Yeah, signal void areas suggest that this is likely a hematoma, and I would inform the referring physician
you
about.
Describe this like blood products that's causing this blood susceptibility artifacts.
Yes.
Okay. Okay. Actually, this patient had further CT scan. Okay. And I want to show you You see any abnormality in the topogram?
On the topogram, I can see that there are few wires noted or projected over the cervical spine, and also I can see that there is tracheal shift towards the left side.
Yeah.
So they could be
by the mass effect of the wires mentioned. But actually, Sadiq, this is not a typical appearance of post-operative wires, especially in those types of surgery. So, can you suspect anything from this?
So
this is in this region, the zero profile device they used to insert in the C5-6 disc. Okay, but this actually was very strange for me.
This could be a foreign body. This could be something left by the surgeon.
What we call
Gaussy pyboma.
Yes, amazing. You are very, very clever, Sadosh. Okay, we have a classic appearance of Gaussy pyboma, which is a spongiform appearance with air bubble-like. Okay, and the curvilinear metallic structure seen in this at the site of operative bed. It's compressing the esophagus, okay, to the left side and slightly the trachea, okay. As we can see here, we can see Okay, this is the intervention he performed. This we call this a zero profile device. Okay, and here we have a Gaussian biboma. Okay, it was a very strange case for me, Sadish, because I have never seen a Gaussian biboma in this location. I have seen it in very strange locations, but actually I have never seen Gaussian biboma post cervical surgery. Okay, and this is the 3D images. Okay, so you are amazing, Sadish, because you have reported the case in a very good way in the pre-operative setting, and in the post-operative setting also you could be able to reach out the final diagnosis. Thank you very much, Sadish.
Thank you.
Okay.
Thank you.
We will shift to our last case today.
Candidate number 9. Candidate number 9. Candidate number 10.
Assalamu alaikum.
Wa alaikum salam. Your name is Sarah?
Sarah.
Okay, you want to share
Yes.
with me?
Okay.
If you want to move the cases, okay.
I can't. Could you please move the case?
Okay. I will start with the history. He was 19 years old male. He presented with diffuse severe bone pain, fatigue, low-grade fever, laboratory workup revealed pancytopenia, elevated ESR, CRP, alkaline phosphatase, and LDH. The history is very important in this case. Okay.
Diffuse pain and
Yes.
lab changes.
Low-grade fever,
Okay.
pancytopenia. Those are the most important 3 clinical findings and laboratory workup.
Okay.
This is the T2 of the cervical dorsal region, and this is T2 of the dorsolumbar region.
There's diffuse bone changes, more evident in the lumbar. Low T2 signal of the bone marrow. Okay. And few 5, 4, 3, 2, 1 around D12 and L1. There is hypo intense lesions in D12 and L1. There is also reduced curve of the lumbar lordosis.
Okay, look, Sarah, what you are doing is not a very good way for reporting. Okay. Just a word from here and a word from there, and if everything I remember I report, it's a very very bad manner in reporting. So what I will do or I would do is to start with like a template. Okay, I will start commenting on the alignment as you said. We have a straightening. Okay, number 2, we will focus on the marrow signal of the vertebrae. Okay, number 3 on the discs. Number 4 on the spinal canal and the spinal cord. Okay, so if you report it this way, you will be your report will be very organized, and you will be conclusive in the end. Okay, so it's our problem here is not about the straightening, and it looks like we don't have any spondylodegenerative changes like in the other case. Okay, but rather the hallmark of this disease or of this patient involving the bone marrow. Okay, we have 3 pathologies involving this marrow of this patient. Can you tell me the 3? What are the 3 abnormalities you can see?
Reduced T2 signal and diffuse reduced signal. Okay.
Overall patchy abnormal signal. Okay, this is not normal marrow signal of the examined bones. Okay, we have a diffuse low marrow signal, and it appears like patchy on T2 and stay with it images. Okay, and on T1 it appears like low T1. Okay, this is the first abnormality. The second abnormality you have already mentioned, which are those well-defined lesions of abnormal low signal. Okay, this is the second abnormality. We have a very, very important third pathology in this case. Can you see it here?
Where? No, I can't see it.
This geographic areas.
Okay, the geographic areas of in the lumbar.
Yes.
T-third. Is there someone? I have no idea about it.
Okay, in the T1 it appears a little bit high.
Yes.
Okay. This appearance reminds you of any disease, any pathology?
I don't know.
Geographic areas of abnormal signal, high signal in T1.
Bone infarction?
Infarctions, yes, yes.
Yes.
Okay, many reported that those are a classic appearance of bone infarctions. Okay. انا مش عارفه ايه المرض اللي اتكتب ده، في مرض كده اتكتب، المهم اوكي. So we have three main pathologies in this case. We have diffuse patchy low marrow signal, we have lesions of abnormal marrow infiltrative signal, and we have multiple
I'm
bone
sorry,
infarcts.
Dr. Dalia, can I interrupt you for one point?
Okay. Okay.
In the sagittal, can you present again the sagittal T1 for the whole spine? Because you told, yeah, stop here, please. We need to announce one important point here. How can we determine is this normal marrow signal or not? You should compare the normal signal of the marrow compared to the disc in the T1.
Yes.
If it is lower than the disc, so this one is abnormal. Normally, the normal marrow signal in T1 should be higher than the disc signal, okay? So this one, that's why Dr. Dalia said we have abnormal signal in the T1, as she said. Okay, thank you.
Thank you, Dr. Muhammad. Okay, this patient also had MRI of the pelvis. We can see similar changes. برضو multiple bone infarcts، وبعدين بقى في بيري اوسيس وسوفت تيشو كده إديمة reactive. اوكي مش فاكرة ده كان ايه. He had the CT scan of the chest. Can you see any abnormality in the bone window in this patient?
Would you change? Yes.
Actually, it's very hard to say anything.
There's hemangioma, I guess, in dorsal spine.
No, I mean the abnormal marrow signal. We can't see any abnormality corresponding in the CT. Okay, but we can see here we have hepatosplenomegaly, which were evident in this case too. Okay. The liver and spleen were enlarged. So let's get back to the case. What's your differential diagnosis for this case?
Blood disease causing hepatosplenomegaly.
That's amazing. You know, that was the very things. Yes, yes. Like many have said, this is a sickle cell disease. Okay, but I will tell you, when we were thinking, I was thinking with my residents regarding this case. He is a 19-year-old male patient. Okay, how come he got to this age and he is not diagnosed with sickle cell disease? Have you asked yourself this question? Okay, I mean a 19-year-old male patient will be well established bone infarction, sickle cell disease.
I didn't say sickle cell. I just said it may be blood disease causing hepatosplenomegaly. Okay.
Yes. Okay. No, actually,
maybe
we have thought of blood disease actually, and we have thought of sickle cell disease. Okay, because of the multiple bone infarcts, and this presentation actually fits with sickle cell crisis. But there were a lot of things against this possibility. Number one, the old age of the patient, and he is still not diagnosed with sickle cell disease. Number two, the diffuse abnormal marrow signal, okay, involving the rest of the marrow. Number 3, the focal lesions which appeared here, okay, those were scary for us. Number 5, the presentation with pancytopenia, okay, and the elevated ESR, CRB, alkaline phosphatase that was okay.
leukemia, lymphoma.
Muhammad said hemophilia or blood disease. Actually بالظبط كده exactly in sickle cell زي ما قلت in 19-year-old patient it will be established sickle cell disease, so you will find the spleen small and they call it Rux spleen, sclerotic and or calcified spleen, okay, but in this case no, we have hepatosplenomegaly, we have diffuse abnormal marrow signal, we have multiple marrow infiltrations, okay. So actually we were worried about a very important possibility in this case. Can someone guess what is the very important and risky possibility in this case?
Leukemia or lymphoma? Or
yes, exactly, Dr. Muhammad. Leukemia. Yes, leukemia more than lymphoma. Okay, leukemia in these cases. So why would leukemia cause this kind of bone infarcts? This patient haven't started any corticosteroids yet, okay, so why did he had this bone infarct?
Hyperproliferation outweighing the blood supply of the
Actually the tumor cells cluster and form like tumor emboli, okay, leading to closure of the blood vessels of this vertebrae, leading to this appearance of the bone infarct, okay. And actually this patient was proved to be acute lymphoblastic leukemia, okay. He had the bone marrow aspirate. Actually we have called this patient, we have confirmed that he doesn't complain of any blood disease, especially sickle cell disease.
In the posterior mediastinum. I think we finished our session today. I think our session was full of many cases. Really, I would like to thank all the audience, all the volunteers, and I hope you enjoyed our session today. Inshallah, this session